Morning, everyone. Today I'll be presenting on a topic mediastinum and mediastinal masses. We'll be covering this topic under further subheading including the clinical anatomy of mediastinum, modes of presentation, mediastinal masses and their etiology, diagnostic workup, and conclusion. Introduction. Benign or malignant mediastinal masses can develop from structures that are normally located within the mediastinum or that can pass through the mediastinum during development or metastasis of the malignancies that arise elsewhere in the body.
Okay.
Sir?
Yeah.
Your slide is. Okay,
now
carry on.
Yes. Mediastinum is the region present between the pleural cavities within the chest. It is bounded anteriorly by the sternum, posteriorly by the vertebral column and the paravertebral fascia, superiorly by the thoracic inlet, inferiorly by the diaphragm, and on bilaterally it is bounded by parietal pleura. These are the images depicting the boundaries of the mediastinum.
Your slide is okay.
Mediastinum divisions. So according to 4-compartment model, the mediastinum is divided into superior and the inferior compartment. Inferior is divided into anterior, middle, and the posterior mediastinum. The boundaries of the superior mediastinum, according to 4-compartment model, is bounded by superior thoracic inlet, inferiorly by the horizontal line connecting the sternomanubrial junction and the lower part of the 4th thoracic vertebrae. Its contents include the aorta, great vessels, trachea, upper third of the esophagus, upper thymus, vagus and phrenic nerve, lymphatic tissue, and upper thoracic duct. This is the image which is depicting the superior mediastinum from the lower margin formed by the sternal angle and the lower margin of the T4 thoracic vertebrae. Anterior mediastinum is present between the body of the sternum and the anterior pericardium. The image in yellow color is showing the anterior mediastinum. Its contents includes the thymus, mediastinal fat, lymph node, and areolar tissue. Middle mediastinum is bounded anteriorly by the pericardium, posteriorly by the bifurcation of trachea, pulmonary vessels, and pericardium. Its contents includes the pericardium and its content, including the heart, great vessels, carina, lymphatic tissues, and proximal portions of the main bronchi. Posterior mediastinum is bounded anteriorly by the posterior border of the middle mediastinum and posteriorly by the lower 8 thoracic vertebrae and the paravertebral fascia. Contents includes the esophagus, descending thoracic aorta, azygous vein, sympathetic trunk, lymphatic tissues, and thoracic duct. The drawback is that some of the organs or structures which are included into multiple compartments, therefore the location of the organs or structures are not confined to the one. According to the 3-compartment model, the anterior mediastinum also includes the superior mediastinum. Middle mediastinum, also known as the visceral compartment, is present between the anterior and posterior mediastinum. Posterior mediastinum, also known as the paravertebral compartment, is bounded by the superior aspect of the thoracic vertebrae and inferiorly by the diaphragm. Contents are similar to the 4-compartment model. Shields classification. According to Shields in 1972, the original method of dividing the mediastinum, anterior compartment consists of, anteriorly it is formed by the undersurface of the sternum, superiorly by the innominate veins, and an imaginary line formed by the anterior surface of the great vessels and pericardium posteriorly. The middle visceral compartment is formed anteriorly by the posterior superior portion of the sternum above the innominate vein, posterior limit of the anterior compartment below these veins, and posteriorly by the ventral surface of the vertebral column. Bilateral paravertebral cerci, which is the posterior compartment, is not truly a mediastinal compartment. Spaces along each side of the vertebral column just adjacent to the proximal portions of the ribs are included. Thoracic inlet occupied within the middle compartment and 2 paravertebral sulci. The anterior compartment does not directly communicate with the thoracic inlet. The contents of the anterior compartment includes the thymus, internal mammary vessels, internal thoracic lymph nodes, prevascular lymph nodes, adipose and areolar tissue. The contents of the middle mediastinum includes the heart, great vessels, pericardium, trachea and proximal bronchi, esophagus, nerves, including the vagus, phrenic and sympathetic nerves, thoracic duct, descending aorta, pleuropericardial lymph node, and azygous venous system. The contents of posterior compartment includes the sympathetic chain, proximal portions of the intercostal neurovascular bundles, thoracic spinal ganglia, and distal azygous vein.
One minute. The posterior mediastinum includes the esophagus, thoracic duct, and the descending aorta. It does not form in the middle mediastinum. Okay.
Okay.
So that is considered as the thing plus the sympathetic chain that constitutes the posterior mediastinum. The heart and great vessels only are in the middle mediastinum and maybe the proximal pulmonary artery and the aorta. And the rest of it is in the front. Esophagus goes to the posterior mediastinum.
Okay. Coming to the initial presentation, most of the patients present as an incidental finding on imaging, which is done for prior to some elective surgery or as a part of evaluation of some unrelated condition. The findings on the chest radiograph can vary from subtle mediastinal finding to the presence of the widened mediastinum or large mass in the mediastinum. This is a chest X-ray which is showing a mass in the mediastinum with the widening. Symptoms presenting symptoms will be, according to the mediastinal mass effects, direct involvement or compression of the normal mediastinal structures. May present with cough, stridor, hemoptysis, shortness of breath, pain, dysphagia, and change in voice. Facial and or upper extremity swelling due to vascular compression, maybe because of superior vena cava syndrome, hypotension due to tamponade physiology or cardiac compression, Horner syndrome due to involvement of sympathetic chain. Systemic symptoms includes the fever, night sweats, and weight loss in the case of any malignancy, and paraneoplastic syndrome, as in the myasthenia gravis, associated with thymoma. Patient will present with weakness of eye muscle, ptosis, diplopia, dysarthria, and weakness in arms, hands, fingers, legs, and neck. Diagnosis is based on diagnostic markers, imaging including the CT chest, PET scan, and MRI, and tissue diagnosis. Coming first to the laboratory diagnosis, mostly helpful when thymoma or germ cell tumor is suspected, because in thymoma is mostly associated with myasthenia gravis, so anti-acetylcholine receptor antibodies are present. Alpha-fetoprotein is positive in malignant germ cell tumor, specifically for 60 to 80% of non-seminomatous germ cell tumors. Beta human chorionic gonadotrophin, beta HCG, is associated with seminoma only in 10% of the cases and 30 to 50% of the non-seminomatous germ cell tumors. Lactate dehydrogenase may be elevated in patients with germ cell tumors, which is non-specific. Imaging. CECT chest, typically it's used to evaluate the abnormalities which are seen on the radiographs. Gold standard can confirm the presence of the mediastinal mass. It provides the detailed information regarding the mediastinal abnormality, location, size, relationship to other structure. Tissue characteristics, including the presence of fat, fluid, or calcifications, can be seen on CT. Involvement or invasion or compression of surrounding structures is critical in planning treatment and preparing a patient for possible resection. Cardiac gated magnetic resonance imaging is useful in distinguishing compression versus invasion, particularly in cases of large anterior mediastinal masses. Positron emission tomography is usually for middle mediastinal pathology. For a middle mediastinal mass that is suspected to be a lymphoma, 18 FDG with few CT may be performed, and this modality is useful to identify a preferred biopsy site and monitoring response to treatment. False positive cases can be seen in PET, especially in non-malignant condition, including the thymic cyst, normal thymus, thymic rebound state, acute mediastinal lymph adenopathy. Spine MRI, detailed evaluation of posterior mediastinal masses which are adjacent to the spine can be seen in MRI. An MRI is used for determining the extension into the neural foramina important for surgical planning. Technetium scan is used in suspected ectopic thyroid tissue or substernal goiter. Iodine meta-iodobenzyl guanidine scan is used for mediastinal pheochromocytoma, and scrotal ultrasound is used for mediastinal germ cell tumor to exclude the gonadal primary tumor, including the gallium dotatate PET scan is used in thymic neuroendocrine tumors. Tissue diagnosis. Tissue sample required for the definitive diagnosis generally requires a process which can be obtained either by biopsy prior to the treatment or a part of planned therapeutic resection of the entire mass. Biopsy is needed in some cases, but not all cases prior to the definitive treatment. Whatever biopsy, it may be percutaneous, endobronchial, or surgical, pathologist should confirm the adequacy of the diagnostic tissue. It can be done either by cytological assessment or frozen section. A rapid on-site cytological examination has been shown to increase the diagnostic yield of TBNA, that is transbronchial needle aspiration. Performed additional biopsies while the patient is still sedated on anesthesia. Decision to biopsy in clearly resectable mass is difficult. Risk of foregoing biopsy missing the diagnosis in which medical management would have sufficed. Risk of biopsy includes the tumor seeding, especially in case of encapsulated thymoma. Seeding of mediastinal space, pleura, and the needle tract can also happen. Create situation where surgery is no longer curative without adjuvant radiation. Seeding of the pleural cavity is a lifetime risk for pleural recurrence throughout. For posterior mediastinal masses, indication for pre-resection biopsy includes diagnosis has not been established by clinical presentation and imaging. The mass involves structures considered as not resectable but requires extensive and complex reconstruction. In example, neurogenic tumors or sarcomas requiring CT-guided biopsy. If biopsy is still inconclusive, further treatment is based, most likely diagnosis considering the clinical condition, imaging, and pathological characteristics. Now, different types of the biopsy, percutaneous, which is usually CT guided, it can be done for both anterior and the posterior mediastinal masses. Diagnostic yield of percutaneous biopsy of mediastinal mass is 74 to 77%. The advantage is obtaining tissue for diagnosis using local anesthesia on an outpatient basis. Disadvantage is inadequate tissue for diagnosis and failure to make diagnosis in a relatively small mass. Core needle biopsies are better than fine needle aspiration, because fine needle aspiration will not allow differentiation among the possible diagnoses. Larger cores often required for immunohistochemistry and flow cytometry analysis to subtype the malignancies. Second, endobronchial ultrasound-guided biopsy significantly increase the potential yield of this diagnostic procedure. It's reasonable when mass is located immediately adjacent to the airway, including the trachea and main stem bronchi. Difficult to access percutaneously even with image guidance due to the proximity to major vascular structures. Endoscopic ultrasound, which is done via the esophagus. FNC of surgery.
We can't see your slides. We lost your voice.
Now, sir?
Can't see the slides.
Now, sir?
Yeah.
Endoscopic ultrasound via the esophagus, FNE of certain periesophageal posterior mediastinal masses. However, transesophageal FNC should be considered very carefully because of the risk of infecting the cystic fluid. Surgical. If percutaneous and endobronchial route cannot provide adequate tissue, the assessment of adequacy of sample by frozen section. Now, sir?
Yeah.
By anterior mediastinotomy, Chamberlain procedure. This procedure usually performed under general anesthesia. The patient is placed in supine position with arms tucked. A 5 cm horizontally oriented incision is made just lateral to sternomanubrial joint over the second costal cartilage. The pectoralis muscle fibers are splitted from the sternochondral to costochondral junction. The second costal cartilage is removed subperichondrali and the pleura is gently swept laterally to avoid inadvertent pneumothorax. Biopsy is performed under direct vision with a scalpel or biopsy forceps. It reduces the risk of pneumothorax, effusion, pleural seeding of thymomas. Always yield a sufficient tissue for diagnosis. Cervical mediastinoscopy. For lesions in the middle mediastinum, especially adjacent to the airway, mediastinoscope is inserted through a small incision just above the sternal notch and it is directed towards the mediastinum. Lesions in the paratracheal and subcarinal spaces can safely be sampled. An extended mediastinoscopy explores areas which are adjacent to the great vessels, but requires expertise. The video-assisted thoracoscopy approach, it's an excellent anatomical view, also allows for the biopsy of the tissue anywhere in the mediastinum, adjacent to the structures such as the aorta, great vessels, and heart. It relatively causes more postoperative pain. VATS biopsy is generally performed only if another method has failed to achieve the diagnosis. This is the image showing the cervical mediastinoscopy. Coming to the anterior mediastinal masses, the structures present includes the thymus, lymph nodes, ascending aorta, pulmonary artery, phrenic nerves, thyroid, and parathyroid. More than 50% of the mediastinal mass located are in the anterior superior mediastinum. Most common lesion includes the thymic tumor or of lymph node origin. Anterior mediastinal masses are different. Etiologies include thymus, lymphomas, germ cell tumors, intrathoracic thyroid, parathyroid adenoma, hemangioma, and lipoma, liposarcoma. The most important is 4 T's, that is terrible T's, including the thymoma, teratoma or germ cell tumor, lymphoma, and thyroid tissue. And thymus includes the thymoma, thymic cyst, thymic hyperplasia, and thymic carcinoma. The first, thymic hyperplasia. Tumors of thymus are classified into epithelial tumors, including the thymoma and thymic carcinomas, lymphomas, including the Hodgkin's and non-Hodgkin's lymphoma, Langerhans cells histiocytosis, thymolipomas, carcinoid tumor, sarcoma, and metastatic tumors. In adults, thymoma is the most frequent primary tumor of the thymus. Lymphoma is the second most common, followed by germ cell neoplasm. In children, lymphoma is the most common, which is followed by the germ cell, and thymomas are rarely seen. First tumor, that is thymoma. It's a benign low-grade malignant tumor arising from the thymic epithelium with immature reactive and non-neoplastic T cells. 20% of all mediastinal neoplasm in adults are constituted by thymoma. Peak prevalence is seen in 4th to 6th decade of life with no sex predilection. It's frequently asymptomatic. Only in 20 to 30% of the cases, patient presents with pressure-induced symptoms. 30 to 50% of the patients develop myasthenia gravis. Contrarily, 15% of the patients with myasthenia gravis have thymomas. On chest X-ray, typically sharply marginated retrosternal opacity is seen.
We are in thymic hyperplasia still. Yeah.
Okay. On chest X-ray, typically sharply marginated retrosternal opacity, smooth or lobulated borders project to either side of the mediastinum. Systemic diseases which are associated with thymoma includes the myasthenia gravis, cytopenia including the pure red cell aplasia, hypogammaglobulinemia, non-thymic malignancies, thyroiditis, SLE, polymyositis, and rheumatoid arthritis. Thymic CT scans shows homogeneous solid masses, soft tissue attenuation with well-demarcated borders. 2/3 of thymomas are encapsulated, which are oval, round, or lobulated in shape. Large thymomas have areas of cystic or necrotic degeneration. 5% curvilinear or amorphous calcification can be seen. In benign condition, well-defined fat planes between thymoma and adjacent structure is visible. Malignancy, infiltration of fat planes, and irregular interface between the mass and lung parenchyma, encasement of mediastinal structures with pleural thickening, nodularity, and effusion is seen. Thymoma staging includes the MESOCA and WHO staging. The stage 1 includes the encapsulated tumor without any microscopic invasion. The image showing in the stage 1, the separate nodule is there within the capsule, and if any spread is there, direct intracapsular spread. WHO classification has type A, spindle cell or medullary. Type 2A, stage 2A, microscopic invasion is seen into thymus or fat, but not through the pleura and the pericardium. Second B is showing the macroscopic transcapsular invasion, and this is classified in WHO as B1, lymphocyte rich, predominantly cortical. Stage 3 includes the macroscopic invasion involving the neighboring structures, pericardium, great vessels, and the lung, which is in the WHO grading as B2 cortical. The stage 4 includes the pleural or pericardial dissemination, while stage 4 is lymphogenous and hematogenous metastasis, which is in WHO classification as type C thymic carcinoma. Second mass that is most common is lymphoma. It's a common part of disseminated disease or less commonly present as the primarily involvement. Approximately 15% of all primary mediastinal mass in adults and 45% in the children. Majority are Hodgkin's lymphoma, usually arise either from the thymus or the lymph node, thus accounting for predilection for the anterior and the middle mediastinum. Posterior mediastinal involvement is infrequent. The anterior mediastinal and paratracheal nodes are most frequently involved in the case of lymphoma. Isolated hilar node enlargement is uncommon, usually associated with mediastinal nodal enlargement. Primary mediastinal lymphomas are of three histological varieties, including the nodular sclerosing, primary mediastinal large B-cell lymphoma, and lymphoblastocytic lymphoma. In CT, lymphoma is seen as soft tissue attenuating mass with smooth or lobulated margins, which conforms to the surrounding structures, homogeneous, but often demonstrate cystic and low-density areas. Other features include the pulmonary parenchymal invasion, pleural effusion, pericardial effusion, chest wall invasion, calcification, and which can be irregular, diffuse, or even axial calcification. Third is the parathyroid adenoma. It is mostly seen in the upper mediastinum, particularly in the case of ectopic parathyroid, encapsulated round and usually less than 3 cm in size. Conspicuous contrast enhancement is there. MRI or nuclear scans are more effective for the diagnosis. Thymic lipomas, rare, benign, well-encapsulated thymic tumors. About 5% of thymic neoplasms, often very large, mean diameter of 20 cm at the time of diagnosis. It can occur at any age, but most commonly seen at the age of 20 years, with no sex predilection. Good pliability conform to adjacent structures, extend to the cardiophrenic and costophrenic angles. Even occupy almost entire hemothorax, usually asymptomatic for the same region. Compression related to symptoms are delayed. CT shows predominantly fat attenuation, interspersed fibrous septas, and normal thymus. Lipoma is usually well circumscribed, which is originated from the adipose tissue. Seen in the anterior mediastinum, 2% of all primary mediastinal tumors. Its insidious onset typically goes unnoticed until a well-delineated abnormal shadow is seen on the routine chest X-ray. Slow growth, symptom onset due to mass effect, including the compression of bronchi, esophagus, phrenic nerve, or vagus nerve. On CT, homogeneous fat attenuation of approximately -50 to -100 Hounsfield unit is seen. Thymic cysts are relatively rare, of unclear etiology, can be congenital or acquired. Congenital is formed from the remnants of the thymopharyngeal duct, acquired from the inflamed thymic parenchyma. On CT, simple homogeneous cyst, thin walls, no solid component, no contact. Sure.
Okay.
Microscopically, thymic cyst is identical to cystic thymic neoplasm. Thus, though sampling and examination is essential. Pericardial cyst, it's formed by abrasions in the coelomic cavity formation. Cyst wall, it's formed from the connective tissue and single layer of the mesothelial cells, commonly arising from the right cardiophrenic angle, but can be found almost anywhere adjacent to the heart. Mostly asymptomatic, conventional chest X-ray will show well-defined round oval mass near the cardiophrenic angle. CT and MRI imaging features will be like other mediastinal cysts. Lymphangioma, a rare benign congenital malformation because of focal proliferation of well-differentiated lymphatic tissue. 0.5 to 4% of all mediastinal tumors and majority less than 2 years of age. More common in neck and axilla, and 10% extend into the mediastinum, and 1% are confined to the chest. Histological classification includes simple, capillary, cavernous, or cystic hygroma based on the size of lymphatic channel, mostly asymptomatic due to their soft consistency. On CT, they can be seen as smooth lobulated mass which conforms to the surroundings. Homogeneous low attenuation can have higher attenuation combination of the fluid, solid tissue, and fat. Present in multicystic sponge-like accumulation, unilocular or multilocular, with thin septations into the mass. Coming to the heterogeneous masses, including the thymic carcinoma, germ cell tumors, teratoma, and malignant germ cell tumors, and goiter. Thymic carcinoma, 20% of thymic epithelial tumors are locally aggressive, presenting as compressive symptoms. Metastatic spread is seen, 50% are diagnosed at the time of diagnosis. Unlike thymomas, rarely causes paraneoplastic syndrome. On CT, large inhomogeneous multilobulated mass is seen which lack well-defined capsule containing necrotic areas and calcification. Difficult to diagnose thymic carcinoma versus thymoma solely based on imaging findings. Some useful features include the distant metastasis, mediastinal lymphadenopathy indicating the malignancy. FDG PET is useful in differentiating thymic carcinoma from other thymic neoplasm, thymic hyperplasia, and normal physiological uptake. The SUV for thymic carcinoma is significantly greater. Germ cell tumors. 7 to 12% of mediastinal tumors in adults and about 25% in the children are germ cell tumors. It arises along the midline from the perineal region to the sacrococcygeal, including the mediastinum. Anterior mediastinum, most common site of the extragonadal germ cell tumors. Primary tumors are very rare. Benign germ cell tumors have no sex predilection, while the malignant tumors are more commonly seen in the men with peak prevalence in third decade of the life. Histologically, they can be benign teratomas, seminomas, or non-seminomatous, including the embryonal tumor, yolk sac tumors, and teratocarcinomas. Serological markers, the alpha-fetoprotein and HCG is diagnostic evaluation and prognostication. Both pure and mixed germ cell tumors can develop within or near thymus. More than 80% of the mediastinal germ cell tumors are benign, the most common being the benign teratoma. On chest X-ray, typically it is seen as large, round, or lobulated mass. On CT, it's classically inhomogeneous, which is formed by the combination of fat or fluid, soft tissue, calcification, bone, or teeth. Usually encapsulated with or without REM enhancement. It's very difficult to distinguish benign versus malignant. Benign is typically clearly defined and encapsulated, while the malignant is nodular, poorly defined margins, and a more solid component. Features suggestive of malignancy includes the capsule absence, thick and irregular enhancing capsule, and areas of necrosis or hemorrhage. Goiter, most commonly, it's confined to the upper mediastinum. 10 to 15% are located in the anterior and 20 to 25% in the middle mediastinum. These substernal goiters of 10% of the anterior mediastinal masses. On CT, goiter is seen continuous with the cervical thyroid. Mass may deviate and squeeze the trachea or displace the mediastinal vessels.
Yeah.
Now,
Mm.
mass may deviate and squeeze the trachea or displace the mediastinal vessels, usually have a nodular pattern with focal calcifications. The middle mediastinum contents includes the trachea, esophagus, azygous vein, vena cava, heart, aortic arch, and lymph nodes. Middle mediastinal masses, the most common are the cysts, including the foregut duplication cyst, esophageal and bronchogenic cyst, lymphadenopathies, and aortic arch or vena cava anomalies can also develop in the middle mediastinum. This is the donut sign, which is seen on the lateral chest X-ray, which is formed by the normal right and the left main pulmonary arteries and the posterior aspect of the aortic arch anteriorly and superiorly, and inferiorly by the hilar lymph nodes with central radiolucent center formed by the trachea and upper lobe bronchi, which is seen in the middle mediastinal masses. Middle mediastinal masses includes the soft tissue lymph nodes, lymphomas, and esophageal carcinomas. Fat masses includes the lipomas. Liquid masses includes the cyst, including bronchogenic, pericardial, and esophageal duplication cyst, vascular anomalies, and gastroesophageal hernias. First, soft tissue mass, including the lymph node, lymphomas, exhaustive spectrum of pathology, including the infective, malignancy, connective tissue disorder, autoimmune disease, occupational lung disease, and other interstitial lung diseases. There are no elements allowing a certain differential diagnosis. Tuberculosis includes enlargement, cases, necrosis, and calcification is seen. Sarcoidosis, silicosis, and fungal pneumonia often are partially calcified. Hypodense appearance, size greater than 2 cm, and the round morphology suggestive of malignancy. So in middle mediastinal, homogeneous mass constitutes the lymphoma and the lipoma, which is similar to the anterior mediastinum. Now the duplication cyst, foregut duplication cyst, cystic masses in the mediastinum are well marginated round elliptical lesions that contain fluid and are lined with epithelium. The majority of them includes the bronchogenic, esophageal duplication cyst and pericardial cyst. Bronchogenic cyst, congenital malformations of the bronchial tree, which is lined by pseudostratified columnar epithelium. Walls is formed by the cartilage, smooth muscle, mucous gland filled with clear serous fluid or dense mucoid material. Any part of the mediastinum, but most near the tracheal carina in the middle or posterior mediastinum is seen. Majority of the patients are asymptomatic and symptoms which are secondary to the compression of adjacent structures. Abrupt increase in size can be result of the hemorrhage or infection. On chest X-ray, well-defined solitary mass with homogeneous opacity just inferior to the carina can be seen. On CT, single smooth round elliptical mass is seen with uniform attenuation. Approximately 50% of them are of fluid intensity ranging from 0 to 20 Hounsfield units. However, a significant proportion of soft tissue density is more than 30. Even hyperdense high protein level or calcium oxalate is seen in the mucoid cyst. Calcification is occasional, especially in the wall, classically with no contrast enhancement. Air within the cyst is uncommon. If it is present, it is suggestive of infection and fistulization within the air. Esophageal duplication cyst. Uncommon, more commonly present in males. Congenital malformation of the posterior primitive foregut. Cause includes the posterior division of the embryonic foregut aberration at 3rd to 4th week of gestation. Commonly lined by gastric epithelium, majority of the patients are asymptomatic, occasionally presenting with dysphagia, pain, or compressive symptoms. Ectopic gastric mucosa is prone to infection, perforation, and hemorrhage. Majority of the infants usually adjacent to or within the esophageal wall. On CT or MRI, identical to bronchogenic cyst, except that wall may be thicker and intimate contact with the esophagus. Pericardial cyst, its incidence is 1 in 1 lakh persons, most commonly seen in the right cardiophrenic angle. It's asymptomatic, but 20% of the patients will present with dyspnea, cardiac compression, infection. Treatment consists of percutaneous drainage or surgical resection. Pericardial neoplasm are rare. If present, mesothelioma is the most common. Metastatic neoplasm to the pericardium from lungs, breast, prostate, lymphoma are far more common than primary tumors. Liquid vascular anomalies includes the aortic aneurysm and left superior vena cava, the vein of Marshall. Left superior vena cava is the most common congenital venous anomaly in the chest. Minority of the cases can result in right to left shunt. Prevalence is 0.3 to 0.5% of normal population. CT is able to demonstrate the anomalous vessel, and a communication with the normal right SVC is present in 90% of the patients. Azygous continuation of the inferior vena cava, which is because of the absence of the hepatic segment of the IVC with azygous continuation. It's an uncommon vascular anomaly caused by dilated azygous vein. Its prevalence is only 1.5%. Hepatic segment of the IVC is absent, and hepatic veins joins and drain directly into the right atrium. On frontal chest X-ray, the mediastinum is widened and azygous arch is enlarged. Cross-sectional imaging usually has no difficulty in identifying the abnormality. Gastroesophageal hernias or diaphragmatic hernia. The sliding type of the diaphragmatic hernia in which the distal esophagus lies along the herniated stomach above the hiatus. Air fluid levels or herniated gastric folds may be present in the hiatal sac. More common than periesophageal type, diaphragmatic hernias can be congenital or acquired defects in the diaphragm, congenital being Bogdeleg and Morgagni hernia. Bogdeleg is the posteriorly located, present in the infancy, and Morgagni is a small anterior with delayed onset. Or it can be because of the acquired causes, including the traumatic diaphragmatic rupture or iatrogenic causes. Esophageal diverticulars, it can be because of sac or pouch projections arising from the esophagus. It can be seen in any age group, more frequently adults and elderly people. CT and barium contrast and INST fluoroscopy are useful for the diagnosis. Esophageal diverticula are either true diverticula, including all the layers, or false, containing only the mucosa and submucosa herniating through the muscular layer, as seen in the Zenker's diverticulum. Esophageal leiomyomas, benign smooth muscle neoplasm of the esophagus, most common benign tumor of the esophagus. It is seen in the young and middle age group of 20 to 50 years. CT findings includes the oval intramural solitary mass with a smooth surface, the presence of calcification, narrowing of the esophageal lumen, displacement of the esophagus, diffuse contrast enhancement, and no signs of invasion of adjacent tissue. Esophageal carcinoma, which is 4 to 10% of all GI malignancy, it's more commonly seen in males of a squamous subtype, may appear as intraluminal mass or localized thickening with tumor growth circumferential with or without intraluminal neuron. CT is useful in staging and can demonstrate the thickness of the lesion and involvement of the periesophageal tissue nodes and tracheobronchial tree. Esophagus lacks a serosa, so that direct local invasion by the esophageal carcinoma is frequently encountered at the diagnosis. Intrathoracic sarcomas, sarcomatoid neoplasm are broad group of tumors. It includes the lung, mediastinum, pleura, and the chest wall, having a mesenchymal component. On CT, they appear as large, invasive, and very heterogeneous with liquid necrotic areas and calcified masses. The posterior mediastinal mass include the contents, lymph nodes, sympathetic ganglia, parasympathetic chain, nerve roots, descending thoracic aorta, thoracic duct, and small vessels. Posterior mediastinal mass tumors include first intercostal nerve tumors, including neurofibroma, neurofibrosarcoma, neurosarcoma. Sympathetic ganglia tumors include ganglioma, ganglioneuroblastoma, and neuroblastoma, and paraganglioma tumors includes the paraganglioma pheochromocytoma. In posterior mediastinal mass, cervicothoracic sign is seen. The anterior mediastinum usually stops at the level of superior clavicle. Therefore, when a mass extends above the superior clavicle, it is located either in the neck or in the posterior mediastinum. When lung tissue comes between the mass and the neck, the mass is probably in the posterior mediastinum. Posterior mediastinal mass includes first neurogenic tumors, which are derived from the neural crest. It represents 20% of adult and 35% of the pediatric tumors. Most common being 95% in the posterior compartment. Neurogenic tumors are most often benign in 70 to 80% of the cases. Nearly half are asymptomatic, occasionally presents with compressive or neurological symptoms if they are malignant. Peripheral nerve sheath tumors, benign and slow-growing tumors, consist mostly of the neurogenic mediastinal tumors. Schwannomas constitute 50% of these masses. Encapsulated masses consisting of Schwann cells and frequently affect the patient 20 to 30 years of the age. Usually solitary, but multiple schwannomas may be associated with neurofibromatosis type 2. Neurofibromas are non-capsulated and soft. A plexiform neurofibroma represents diffuse involvement of the long nerve segment and its branches with a bag of worm appearance. It is often asymptomatic and discovered incidentally. On chest X-ray, nerve sheath tumors are sharply marginated, spherical or ellipsoid masses. On CT, low attenuation can indicate the cystic changes or the presence of lipid within the myelin. Being adjacent to the spine, they can cause erosion, deformity of the ribs and ventral bodies during growing. Rarely growing through intervertebral phenomena, creating a dumbbell or hourglass appearance on the CT images. MRI is used to rule out the intraspinal extension. Sympathetic ganglion tumors, which arise from the neuronal cells rather than from the nerve sheath. Benign encapsulated ganglioneuroma to the aggressive malignant non-encapsulated neuroblastoma. It can arise from adrenal glands or in the sympathetic ganglia. Ganglioneuromas and neuroblastomas arise mostly in sympathetic ganglia of the posterior mediastinum. 50% of the neuroblastomas arise in the adrenal glands and up to 30% are in the mediastinum. Ganglioneuroma are the benign tumors composed of one or more mature ganglionic cells, most benign and differentiated of the autonomic ganglionic tumor. Most patients are asymptomatic, usually diagnosed in second to third decade of the life. Radiologically, the tumors are oblong and well marginated, occurring along the anterolateral aspect of the spine and spanning of the 3 to 5 vertebrae. CT scanning is not useful as the mass can be homogeneous or heterogeneous. Boctelic hernia, congenital diaphragmatic hernia occurs posteriorly, defect in the posterior mediastinum of the diaphragm when there is failure of the pleuroperitoneal membrane closure in utero. Retroperitoneal structures may prolapse through the defect CT usually demonstrate a fat above the diaphragm and extremely affecting, revealing an organ entrapment. A useful mnemonic for remembering the features of Bogdelic hernia is 5Bs, Bogdelic, big back, medial, usually on the left side. Liquid masses includes the meningocele, intrathoracic meningocele, anomalous herniation of the leptomeninges through an intervertebral foramina or a defect in the vertebral body. This anomaly is associated with neurofibromatosis, mostly seen in adults, and are frequently asymptomatic. On conventional radiograph, they appear as sharply defined, round, smooth, or lobulated paraspinal masses. At CT, they appear as well-defined, homogeneous, low attenuation paravertebral masses. Other findings
Not
include
right. Can't see you. Not right.
now, sir.
Yeah.
Other findings may include the enlargement of intervertebral foramina and associated vertebral and rib anomalies or scoliosis. Malignant peripheral nerve sheath tumors are spindle cell sarcomas of the posterior mediastinum. It includes malignant neurofibromas, malignant schwannomas, and neurogenic fibrosarcomas. They affect men and women equally in third to fifth decade of the life and are closely associated with neurofibromatosis. The most common presenting symptom will be pain and nerve deficits. Sympathetic ganglion tumors, ganglioneuroblastomas, have histological features of both ganglioneuromas and neuroblastomas. Symptoms may arise due to large tumor size, intraspinal extension, and metastasis. Staging is similar to that of the neuroblastoma. Neuroblastoma is a disease of young children with 95% occurring in patients of around 5 years of the age. These are highly aggressive and metastatic tumors. They are non-encapsulated lesions, often exhibiting hemorrhage, necrosis, or cystic degeneration. Symptoms include pain, neurological deficits, Horner syndrome, respiratory distress, and ataxia. Neuroblastomas have highest propensity of any tumors in its class to produce vasoactive substances that can cause hypertension, flushing, and diarrhea. Grossly, these tumors appear as elongated paraspinal masses, sometimes impinging on the adjacent structure, causing skeletal damage. On CT, 80% of these tumors have calcification. MRI is useful to define the extent of intraspinal involvement. Conclusion: CT is the most important diagnostic modality while evaluating the mediastinal masses, except for the posterior mediastinal tumors of neurogenic origin. MRI scans are superior to CT in defining the vascular involvement and in distinguishing the recurrent tumors from radiation fibrosis. In addition to the accurate assessment of the nature of the mass, CT also can detect the fat and calcium within the tumor. The relationship surrounding structures, extent of invasion is also accurately assessed by the CT scan. FNAC is considered as adequate evaluation when done under guidance by USG or CT. However, core biopsies are preferable whenever lymphoma or thymoma is suspected. This is the last image, which is showing the differential diagnosis of the tumors in different compartments, including the anterior, middle, and the posterior. The anterior, the most common being thymomas, which can be benign, malignant. Lymphomas, including the Hodgkin's disease, lymphocytic lymphoma, histocytic lymphoma, and undifferentiated. Germ cell tumors, including the seminomas, embryonal carcinoma, and choriocarcinoma. And parathyroid edema and retrosternal goiter. Second, in the middle compartment, mostly is the cyst, pericardial cyst, bronchogenic cyst, and esophageal duplication cyst. The posterior compartment, including the neurogenic tumors, neurofibroma, neurolemoma, and pheochromocytoma and ganglioneuroma. So creating a differential diagnosis of the mediastinal mass is based on localization and characterization. Anatomical is based on the sagittal radiograph imaging, X-ray, CT, and MRI, and in terms of the fluid, fat, and vascularization seen in the CT. Thank you, sir.
Okay. The may I ask you what is your reference for all these for this topic?
So Sebastian, I have Sebastian.
Because you're basically, I have a problem with your initial classification itself. Like the posterior mediastinum contains all the like esophagus, the thoracic duct, the descending aorta all forms the posterior mediastinum along with the neurogenic component. So that is important. Secondly, in the middle mediastinum, the classification like your 4 T's in the anterior mediastinum, the 3 A's in the middle mediastinum. Those are aneurysms. You didn't talk about pulmonary artery aneurysm. You didn't talk about aortic aneurysms. And the anomalies of developmental anomalies, that is the various pericardial, bronchogenic, and esophageal duplications may come into that. Esophagus basically goes to the posterior mediastinum. And then, of course, the abnormal lymph nodes. So these are the 3 A's in the middle mediastinum, and then, of course, the 4 T's in the anterior mediastinum. Basically, this thing was completely theoretical, but from a practical point of view, this last slide that you have shown is what is important. You have to know the differential diagnosis of the mediastinal tumor that you see or come across on a patient and how to go about it. You didn't talk about anything about these various diagnostic modalities for different conditions, such as tumor markers for the germ cell tumors. You didn't talk about the tumor markers for the thymic. Basically, how you have to differentiate whether this is a thymic tumor, this is a thyroid tumor, this is a germ cell tumor, or this is a lymph node. And then what are the tests that you do, how you're going to go about it, and you didn't mention anything about the treatment part of it, of all these conditions. So you can't, you see, if you're given a question, mediastinal tumors in your exam, you can't say that I will do this thing only this time and then I'll come next year and write the treatment part. That is not possible. You have to complete everything in one go. So the differential diagnosis, you take the differential diagnosis, various relevant and important investigations to differentiate the two, differentiate between each other, and then the treatment part. And then treatment part, the approaches that are available, whether you're going to do a sternotomy, whether you're going to do a thoracotomy, bilateral thoracotomy, clamshell, how you will decide these things. These are important things. Basically, this whole thing has to be oriented for practical management, how to decide which one you are going to operate, what are the things that decide whether this patient is inoperable, how are you going to access this tumor, what is the approach. These are important things. And as Jairaj sir always says, what is NH experience? You didn't have anything to say about the NH experience. Most of these things are theoretical, taken from a book. You could have got all these tumors on all these things from our own experience. If you had contacted one of the either Deepa or Akhil, they could have given you the whole statistics of what we have done here. You know.